Hi guys, so today we are going to discuss about the middle third fractures. So in this, first we are going to discuss about the mid face. So this portion is called as mid face and the mandible is present over here. So this portion is known as mandibular area. So any fracture in this area is known as middle third fracture. Any fracture in this area known as mandibular fractures. Fine. So the middle face or the mid face, it has these portion. It is the lateral mid face and this portion is the central mid face. There are two lateral mid face areas and one your central mid face. So what is mid face? It is an area between the superior plane which is drawn through the zygomatico-frontal sutures tangential to the base of the skull, and an inferior plane at the level of the maxillary dental occlusal surfaces. This surface. So these planes, they do not parallel each other, but they converge posteriorly at the level approximating that of the foramen magnum behind this, somewhere around here behind the skull. So the triangular region with its widest dimension facing anteriorly, this is the triangular region with the widest dimension. This is what we called as central midface. So what all are the bones which constitutes the middle third of the face? So in this we have the maxilla, the left and the right, the palatine bones, we have the zygoma, the zygomatic process of the temporal bone which is paired, the nasal bone, lacrimal bone, this is the nasal bone, the lacrimal bone, ethmoid and its attachment, the inferior concave pterygoid plates of the sphenoid, this is the sphenoid bone, and vomer, somewhere around here, vomer. Fine. So in this we have the frontal portion, we have the parietal bone, we have the temporal, occipital, sphenoid and ethmoidal also. So these are the bones which constitutes the middle third of the face. So what starting with the biomechanics, so it sustains the masticatory force and provide the normal occlusion or the normo-occlusion. They provide the support for the soft tissue which envelop with a complex facial expression, basis for the aesthetics in the facial height and the width. They protect the vital organ system and their function like the eyes, the nose, lips, ears. Right? So they protect the vital organ system and their function. So coming on to the facial buttresses. So this is the area, and in this the central midface, that one is the central midface. These are having a very fragile bones that could easily crushed when it subjected to strong bone, when it is subjected to your Costco cricket ball, when it hits directly, many bones they get crushed, because this is the area, the central midface, it carries the fragile bone which easily tends to. So they are surrounded by the thicker bone of the facial buttresses system and lending it some strength and stability. So the midface buttresses, these are composed of the frontal bone, the maxillary bone, zygomatic bone and the sphenoid bone, and their attachment to one another. So in this we have two types of buttresses. We have the vertical one, we have the horizontal buttresses. See, take it as a central area or the central midface. When any strong force hits on our central midface, because it carries fragile bone, it tends to crush or it tends to fracture easily. Coming on to the components, as I've already told you, we have the vertical buttresses, we have the horizontal one. So the vertical buttresses, these are the nasomaxillary, important for your MCQs. Nasomaxillary, it contains zygomaticomaxillary, it contains pterygomaxillary and vertical mandible. Vertical mandible. Fine. This is the nasomaxillary, the zygomaticomaxillary, the pterygomaxillary and vertical mandible. So what is the function of the vertical buttresses? They resist the occlusal load. Important. And second buttresses is the horizontal buttresses. In this, first we have the frontal bar. We have infraorbital rim. Right? We have the hard palate and the maxillary alveolus. Fine. So these are the horizontal buttresses, important. And what is the function of these? They interconnect and provide the support for the vertical buttresses. This was the mandible one was the vertical buttresses. So the horizontal buttresses, they interconnected and they provide the support for the vertical buttresses too. Fine. Important. Please note it down. So next is the nerve supply. So the middle third of the face, it is supplied by the second division of the trigeminal nerve. As you know, the trigeminal nerve, it has three divisions. Number one, it has an ophthalmic branch, it has a maxillary branch or the second branch, third branch is the mandibular branch, but the middle third is supplied by the second branch, that is the maxillary. Coming on to the blood supply, so the facial region, it is supplied by the branches of the external carotid artery. Important. So the maxillary nerve branches, it has an infraorbital, it has a posterior superior alveolar, palatine, nasopalatine and zygomatic nerve. So after this, let's discuss some of the typical causes and very important, some of the typical causes of the maxillofacial injuries. So in this, we have the injuries due to direct violence. We have the injuries due to indirect violence. So what all are the injury which comes under the direct one? In this, first you have the altercation and the interpersonal fights. Right? Second is your fist fight, which is very dangerous because it tends to lead a number of fracture in your maxillofacial region. Fist fight, your blows due to stick, due to metal rods and bricks. Third is due to fall, due to road traffic accidents, or due to any occupational hazards, like the athletic injury or industrial mishaps. Fine. Coming on to the indirect violence. So in this, fall from a height due to counter coup fractures important, or due to excessive muscle contraction, which leads to the fracture of coronoid process. Important. So these are the typical causes of the maxillofacial injuries. So after this, next we are going to discuss a very important scale, that is the Glasgow Coma scale. Very important, usually asked question or usually asked MCQs. So in this, please keep this in mind that we have E, that is eye opening, M, that is best motor response, and we have V, that is the best verbal response. So we have to scale it out on the basis of your eye opening, your best motor response, and your best verbal response. Number 1, we have eye opening, which denotes with capital E. Fine. So in this we have scale 4, which leads to or which opens the eyes spontaneously. Scale number 3, in which opens eyes to the voice. 2, opens the eyes to pain. And scale 1 is when there is no eye opening. Right. Second is your best motor response, which denotes with M. In this, it has 6 scales. Scale number 6, which obeys the command. Fifth scale is it localizes to the pain. Fourth scale suggests that withdraws to pain. Third scale, abnormal flexor response. Second, or scale number 2, is abnormal extensor response. 1 is when there is no movement. Right? And third and the last one is your best verbal response, which is denoted with capital V. Fine. So it consists of 5 scales, in which scale number 5, it has appropriate, it is appropriate and oriented. 4 is confused conversations. Third is inappropriate words. Second is incomprehensible sounds. And scale number 1, it stands for when there is no sound. Fine, please go through it once. It is very important for your MCQ. Please note it down. Coming on to the Rowe and Williams classification. So in this we have 2 components which involve A and B. See, A is the fractures that not involving the dentoalveolar components. In this we have a central region and we have the lateral region. This is the central, these are the lateral region. So in the central region, A is the fracture of the nasal bone or the nasal septum, lateral nasal injuries and anterior nasal injuries. Second is the fracture of the frontal process of the maxilla. Third is the fracture of type A and B, which extend into the ethmoid bone. D is the fracture of type A, B and C, which extends into the frontal bone. Fine. And lateral, these are the lateral region, the fracture involving the zygomatic bone and the arch and the maxilla, including the dento-alveolar component. So first is the fracture which is not involving the dento-alveolar component. Next is the fracture that involving the dento-alveolar component. We have the central region, which is of pyramidal in shape, and we have the lateral region. So the central region, the dento-alveolar fractures and the subzygomatic fractures, and combined with the central and the lateral region, we have the high level fracture. We have the Lefort, you can say Lefort 1, Lefort 2, Lefort 3 fractures. So according to Donack-Andrus method classification, which was given in 1998, so in this we have Lefort 1, Lefort 2, Lefort 3 and zygomatic or the tripod. So the proposed designation, in which we have the right and the left. So in the right and the left, the first is the Lefort 1 fracture, which is also known as the Guerin fracture. Fine. So in the left side, it involves the V1I, the V2I and V3. So this area is the area of Lefort 1 fracture, same as that of the right side. Fine. And Lefort 2 fracture, it involves, on the left side we have V1S, we have V2I, this is V2I, and we have V3, this is the V3, and H2, this portion is H2. So this area is your Lefort 2, same as that of the right side. So in the Lefort 3 fracture, we have V1S, so this area, V2S this area, V3 this area, and H2 this area. So this involves this area, particularly the eye portion. Fine. And same as that of the right side. Now coming on to the zygomatic or the tripod, so it involves the V2S this area, V2I this area, and H2 this area, and H2I this area. It involves this area, that is why it is called as tripod. So after this, let's discuss the Rowe and the Kiley classification, which was given in 1968. So in this we have total 8 types. So in which first type, it has no significant displacement. Type 2, which involves the fracture of the zygomatic arch. Type 3, which includes or which involves the rotation around the vertical axis, in which inward displacement of the orbital rim and outward displacement of the orbital rim. In type 4, we have the rotation around the long axis, in which there is medial displacement of the frontal process, lateral displacement of the frontal process. In type 5, we have the displacement of the complex en bloc, in which we have medial, inferior and lateral surfaces. While type 6, we have the displacement of the orbitoantral partition, which can be superiorly and inferiorly and superiorly. Type 7 involves the displacement of the orbital rim segments, and type 8 involves the complex comminuted fractures. So the Larson and the Thompson in 1968, they defined the 3 groups, that is group A, which means that it's the stable fracture. It shows the minimal or the no displacement and it does not require any intervention. Group B, which is involves the unstable fracture with a great displacement and disruption of the frontozygomatic suture, and the comminuted fracture which requires the reduction as well as the fixation. While the group C, which involves the stable fractures, other type of the zygomatic fractures which require the reduction but it does not require any fixation. See, in group 1 there is no intervention, while group B, they required the reduction as well as the fixation, and group C, they require the reduction but they does not require the fixation. Now after this, coming on to subunits, so in this we have the Le Fort fractures, the nasal fractures, and the NOE, which means the naso-orbital ethmoidal fracture, palatal fracture, and the zygomatic fractures. So the mid-face fractures, they generally were used to treat by the close reduction, important, all the mid-face fracture. As a result, the preoperative imaging needs were only those that can identify the presence of the fracture. So the imaging of the middle third, this includes the occipitomental with the standard of 10 degree, 15 and 30 degree, important for your MCQ. True lateral, soft tissue lateral, occlusal, intraoral submentovertex, which is very commonly used, important MCQ. CT scan, 3D CT scan and MRI to detect the CSF leaks and the fistula. Now very important lines are the Campbell's line and the Trapnell's line, important. So the first line, this is the first line, they across the zygomatico-frontal, they crosses the zygomatico-frontal superior margin of the orbit and the frontal sinus. This is the first line. Second line, it crosses the zygomatic arch, zygomatic body, inferior orbital margin and the nasal bone. Third line, this is the third line which across the somewhere around here condyles, the coronoid process and the maxillary sinus. While the fourth line, this line it crosses the mandibular ramus and the occlusal plane. This is the occlusal plane. And the fifth line is known as Trapnell's line. They across the inferior border of the mandible from the angle to angle. Fine, important for your MCQ. Now coming on to the Le Fort fracture, as we know that there are three types of Le Fort fracture, 1, 2 and 3, and modified Le Fort classification, it was given by Marciani in 1993. So Le Fort 1, it has a low maxillary fracture. It is also called as low maxillary fracture, floating fracture or urine fractures. It has modification of Le Fort 1A, that is the low maxillary fracture with the multiple segments. Le Fort 2, which is called as the pyramidal fractures, it has the two modification, Le Fort A, which involves the pyramidal and the nasal fractures too. Second is the pyramidal and the naso-orbital and ethmoidal fracture. Le Fort 3, which is the craniofacial disjunction 3A plus the nasal fracture, and 3B is the naso-orbital ethmoidal fracture, the craniofacial disjunction and naso-orbital ethmoidal fracture. While the Le Fort 4, it has the Le Fort 2 and Le Fort 3 fracture and the cranial base fracture 4A, and supraorbital rim fracture. While 4B, it consists of anterior cranial fossa, supraorbital rim fracture. 4C, it consists of anterior cranial fossa and orbital wall fracture. These are the classification or the modification of the Le Fort classification. So the Le Fort classification in 1901 was Le Fort 1, 2 and 3, and Ehret's classification, which was given in 1942, it can be horizontal, pyramidal and transverse. The classification, which was based on the relationship of the fracture line to the zygomatic bone, are the subzygomatic and suprazygomatic. The classification on the basis of the fracture line, the low level and mid-level and high-level fracture. Starting with the Lee-Ford 1 fracture. So the Lee-Ford 1 fracture, it is also called as horizontal fracture because it passes horizontally. It is also called as Guerin fracture, and it is also known as floating fracture or floating maxilla. Very important for your MCQ. These are very important. This is called as low level fracture. Why? Because the fracture line, it is at the lower level than that of the skull. That is why it is known as low level fracture. It is called as subzygomatic fracture. The fracture line, it lies below the zygomatic bone. That is why it is called as subzygomatic fracture. So these terminologies are very, very important. So there is a separation of a complete dentoalveolar part of the maxilla, and the fracture, it is held only by means of the soft tissue. That is why it is known as floating fracture or the floating maxilla. Why? Because there is a complete separation of the dentoalveolar part of the maxilla, and in this there is a bleeding from the antrum. Important, there is a bleeding from the antrum. So this is a horizontal fracture which is above the level of the nasal floor. Fine. So the fracture line, it extends backward from the lateral margin of the anterior nasal aperture below the zygomatic. From the behind, it is from the lateral margin of the anterior nasal aperture, and then it extends below the zygomatic buttress to cross the lower third of the pterygoid lamina. And the second line, this is the second line which passes along the lateral wall of the nose, and the third line through the lower part of the nose, and then the nasal septum to join the lateral fracture behind the tuberosity. Fine. So in this, I repeat that this is an horizontal fracture above the level of the nasal floor. In this, the fracture line, it extends from the backward from the lateral margin of the anterior nasal aperture and then below the zygomatic buttress to cross the third of the lower third of the pterygoid lamina, and then the second line, this passes along the lateral wall of the nose, and the third line through the lower part of the nose, and then the nasal septum to join the lateral fracture behind the tuberosity. Fine. Coming on to the signs and symptoms. So there is a slight swelling and the edema in the lower part of the face, and there is an upper lip swelling. There is a swelling of the lower part of the face, and there is a swelling in the upper lip, and you can very well differentiate the ecchymosis in the labial and in the buccal vestibule, as well as there is a contusion of the skin in the upper lip, they may be seen. Important is, in this you can see the bilateral nasal epistaxis. Nasal epistaxis means that there is a bleeding from the nose. This is what we call as nasal epistaxis. So there is a bilateral nasal epistaxis or the bleeding from the nose. You can observe there is a mobility of the upper dentoalveolar portion of the jaw. That is why it is known as the floating maxilla, which is mobile to the digital pressure, and bleeding is, and this point is very important, the bleeding is from the antrum. So in this, due to the mobility of the upper dentoalveolar portion, you can see that there will be a disturbed occlusion, and therefore it leads to difficulty in mastication. And of course you can notice that there is a pain while speaking or moving the jaw because of the detachment, or you can say because of the mobility of the dentoalveolar portion, not the detachment but the mobility of the dentoalveolar portion. You can also see that there is sometimes that there will be an upward displacement of the entire fragment, which gets locked against the superior intact structure. Such fracture, it is called as the impacted or the telescopic fracture. And in this you can very well differentiate it, the anterior open bite, or you can say the true open bite. Important for your MCQ. Right? So in this, on percussion of the maxillary teeth, they produces a dull cracked cup sound. Important. When you percuss the maxillary teeth, you can hear the dull cracked cup sound. Now coming on to the LeFor-2 fracture, it is also called as pyramidal fracture because the fracture it is pyramidal in shape. It is also called as subzygomatic fracture. So in this, the force may deliver at the level of the nasal bone. Right? So in this, the fracture it runs from a thin middle area of the nasal bone down of the either side and crossing the frontal process of the maxilla into the medial wall of the each orbit within the orbit, and the fracture line then crosses the lacrimal bone behind the lacrimal sac. Fine. And then the fracture so in this, the fracture line it runs from the thin middle area of the nasal bone down of the either side, crossing the frontal process of the maxilla into the medial wall of the each orbit, and this line crosses the lacrimal bone behind the lacrimal sac before turning forwards to cross the infraorbital margin. They are slightly medial or through the infraorbital foramen. The fracture now extends downward and backward across the lateral wall of the antrum below the zygomatic buttress. And the zygomatico-maxillary sutures, they divide the pterygoid lamina about halfway, and separation of the block from the base of the skull is a separation from the base of the skull. It is completed via nasal septum, and which may involve the floor of the anterior cranial fossa. So what all are the signs and symptoms? Very important, there is a gross edema of the middle third of the face, and this is what we call as moon shape. Commonly asked MCQ. Very important, ballooning or moon shape, and in this you can see that edema it is set within a short time of injury. As soon as the patient get hit by anything or there is a fracture of the middle third of the face, the edema is set within the short time of the injury. In this you can also differentiate, there is bilateral circumorbital edema and ecchymosis. There is a rapid swelling in the eyelids which makes the examination of eye difficult. Important. The signs and symptoms of all the three LeFor fracture guys are very important. Please note it down, because at the end you will just confused up with the moon shape face, with the raccoon eyes, and with the ecchymosis. So please note it down separately. Next is the bilateral conjunctival hemorrhage, which is confined to the medial half of the eye. So the bridge of the nose, this is the bridge of the nose, it gets flattened or depressed. And in this you can easily differentiate the nasal disfigurement. So if there will be an impaction of the fragment against the cranial base, then the shortening of the face with the anterior open bite will be seen. If there is a gross downward and backward displacement of the fragment, then elongation or lengthening of the face will be seen, with the posterior gagging of the occlusion with the anterior open bite, and this you can see that there is a dish-shaped face. See, if the impaction of the fragment it is against the cranial base, then there is a shortening of face. Please note it down. And if there is a downward and backward displacement of the fragment, then there is an elongation or lengthening of the face, or you can say there is an anterior open bite with the dish dish shaped face. Right? So in this you can very well differentiate the bilateral epistaxis, the bleeding from the nose. There is a difficulty in the mastication and speech due to the dearranged occlusion. The airway obstruction may be seen due to the posterior and the downward placement of the fragment which impinge the dorsum of the tongue. In this, the surgical emphysema, which is the crackling sensation transmitted to the fingers due to the escape of the air from the paranasal sinuses. Very important for your MCQ. In this you can see the emphysema. There is a step deformity at the infraorbital margin may be seen. Important. The CSF leak may be present, which is called as the rhinorrhea, and it is from the cribriform plate. Important for your MCQ. I am telling this again that all the signs and the symptoms of Le Fort 1, Le Fort 2 and Le Fort 3 fractures are very important. Only these are the questions which are commonly asked in your competitive exam. So CSF leakage, it may be present, which is called as the rhinorrhea, and it is from the cribriform plate. The anesthesia or the paresthesia of the cheek is very well noticed. After this, let's discuss the Le Fort 3 fracture and the last fracture. So it is also called as high level fracture. Why it is called as high level fracture? Because in this, the fracture line, it passes at the higher level of the skull. That is why it is called as high level fracture. It is also called as transverse fracture because the fracture line, it is passes in a transverse fashion or in a transverse manner. That is why it is called as transverse fracture. It is also called as suprazygomatic fracture. Why? Because the line of the fracture, it lies above the zygomatic bone. That is why it is called as suprazygomatic fracture. And it is also known as craniofacial disjunction. Very important. So in this, the fracture line, it runs nearly from the frontonasal suture and transversely backward, parallel with the base of the skull behind, and involving the full depth of the ethmoid bone and including the cribriform plate. So within the orbit, the fracture, it passes below the optic foramen. This is the optic foramen into the posterior limit of the inferior orbital fissure. From the base of the inferior orbital fissure, the fracture line, it extends into two directions, the backward across the pterygomaxillary fissure. The teardrop shape is a pterygomaxillary fissure. So it extends backward across the pterygomaxillary fissure to fracture the root of the pterygoid lamina. Important. And laterally it crosses the lateral wall of the orbit, separating the zygomatic bone from the frontal bone. And in this way, the entire middle third of the facial skeleton become detached from the cranial base. It gets detached from the cranial base. Right? Very important. High level fracture, transverse and suprazygomatic. Coming on to the signs and symptoms, there is gross edema and there is a ballooning of the face, which is called as the panda faces. Important. And the gross edema, it occurs within 24 to 48 hours of the injury, and in this you can see that there is a bilateral circumorbital edema and ecchymosis and gross edema, and in this you can see the differentiating feature is raccoon eyes. Guys, I am telling you again that please don't get confused if a question comes that the raccoon eyes is present in what type of Le Fort fracture. So your answer should be Le Fort 3, not Le Fort 2. Many of the students get confused between this feature, the raccoon eyes, whether it is present in Le Fort 3 or in Le Fort 2. I am telling you that the raccoon eyes, it is present, it is a characteristic feature of Le Fort 3 fracture only, not Le Fort 2. So the gross circumorbital edema, it will be prevented from the opening of the eye, and in this you can see that there is a hooding of the eyes. Important. there is bilateral subconjunctival hemorrhage where the posterior limit will not seen when the patient asked to look medially. In this, there may be a tenderness and separation of the frontozygomatic suture, and this will lengthening of the face. Why? Because the middle third or the frontozygomatic suture, they detach from the skull, and which leads, when it gets detached, it leads to the increase in the length of the face, or you can say there is a lengthening of the face, and there is a lowering of the ocular level. Unilateral bilateral hooding of the eyes is also seen. The characteristic feature is the dish face deformity. Important. It may be anophthalmos, because the anophthalmos, it is a very important characteristic feature of a blowout fractures. So in this, in class 3, you can be seen, or it may be present, the anophthalmos, diplopia, which is the double vision or the impairment of the vision, the temporary blindness. There is a flattening or the widening or deviation of the nasal bridge. In this, you can see that there is an epistaxis and CSF rhinorrhea. Important. So after this, let's discuss the methods or the treatment or the management of the Le Fort fracture. So coming on to the methods of the reduction for the Le Fort fracture, in this we have the manual reduction, we have the reduction by the traction. So in this, first in the manual reduction, we have the simple manipulation by the hand, dental compound or the impression tray. In this, you can tray the compound impression, the gauze or the rubber catheters, special instruments, and in the reduction by the traction, you can do it by the conservative treatment, supervised spontaneous healing, and open reduction. Starting with the manual reduction, so it is carried out in all the fresh fractures where the fragments, these are not impacted. So as a rule, the arch wires are the first which are to be applied to the teeth. So in the lower jaws, this serves as the template so that the occlusion can be checked. Simple manipulation by the hand is possible in the fresh fractures. In this, the maxilla, it is held between the index and the thumb, and index finger and the thumb, which is brought into the normal occlusion. Another method is to fix the two double wires which encircling the first and the second maxillary molars, and the twisting them individually on the either side. It helps to fix the fracture. So both the twisted wires, these end by means of the wire holders and hemostates, and simultaneously downward movement of the maxilla will help to achieve the normal occlusion. So there is a reduction by using the special instrument. What all are the instruments which we are using for the reduction? So in this, first are the disimpaction forceps that can be used to take the firm grasp of the maxilla and reduce it into its position. Next are the Rose maxillary disimpaction forceps, very important. These are available in right and the left forceps, and these are always come in pair, and it is always used in pairs. So there are two pronged, these are the prongs which the divided forceps, where one prong it fits into the nasal floor, one prong, and another prong it fit into the hard palate. Right? So the anterior traction in case of the split palate, if the palate gets split, in this you can use the Hayton-Williams. So in this, the anterior traction in the case of the split palate, it may be facilitated by the use of a special forceps which is devised by the Hayton-Williams forceps. So in this, it is applied to the buccal aspect of the alveolar processes, and the medial compression, it is exerted until the two halves of the upper jaws, these are approximated. See, in this, when there is a fracture in the palate, the Hayton-Williams forceps, these are applied to the buccal aspect of the alveolar processes, and in this we have to compress it so that the two halves, these are the two halves of the palate, they get into close approximation. Right? So a screw, this is the screw, this is adjusted at the top to prevent the crushing of the bone. Ultimately you can say this is act as a pressure template. So if it is not present, it leads to the force, it leads to the crushing of the two segments. So it can be combined with the Rose maxillary disinfection forceps. Then the stabilized maxillary block, it may be then disimpacted and drawn forward with the help of the Rose maxillary disinfection forceps. Now coming on to the another method, that is the reduction by the traction. So in this, the repositioning of the fractures that are already in the state of the partial fusion, or when attempted manual reduction it is met with the failure, then the reduction by the elastic traction is tried to interdigitate the fractured segments. So it is mainly used in the delayed cases where the fracture is delayed by 10 to 15 or 10 to 14 days old, or you can say it can be used, the method of the traction it is used in the delayed cases when the fracture has occurred in 10 to 14 or 10 to 15 days old and there is no longer sufficiently mobile. So in this, the intraoral elastic traction can be used, the extraoral elastic traction with the appropriate extension bars and the slide bar, the side bars can be used. So the intraoral intermaxillary elastic traction, it may be used in an appropriate direction to restore the normal occlusion, then it should be replaced by the IMF. Coming on to the conservative treatment, so there is a reduction and the fixation of the fractured midface, it indicated in the cases where the surgery is not possible. Why? Due to the poor general condition of the patient, or where there is extensive comminuted with the tissue loss making the internal skeletal fixation impossible. In that case, you can go for the conservative treatment. And it is also used as a supplementary measure with the surgical treatment of the midfacial fracture. Now coming on to the next method, that is the supervised spontaneous healing. So in this, where the mobility at the fractured maxilla is only slight but there is no disturbance in occlusion. So in this, the progress of the healing, it is merely supervised. In this, the patient should avoid chewing and you should advise the patient to take the liquid or the semi-solid diet at least for the first 2 to 3 weeks. Next is the monomaxillary fixation. So this is a method which is used when the tooth bearing section of the maxilla, it is not fractured and then therefore it can serve a fixation point. So in this, the arch bar or the palatal acrylic plate, it can be used. This can be used for the unilateral fracture of the maxilla or the high fracture without the occlusal discrepancies. It is maintained for 6 weeks. Intermaxillary fixation or the IMF, it is maintained for the 3 to 4 weeks as you all know, and at the end of this period the IMF wires and the lower arch bars are removed. Internal skeletal wire suspension. So in this, many times in addition to the intermaxillary fixation, the additional support is required for the immobilization of the jaws. So in that case, the craniomaxillary and the craniomandibular suspension can be carried out using the stable point above the fracture line. So the selection of the site of the suspension wire will be dependent on the level of the fracture line. So this we have already discussed. This is the Rose disinfection forceps. It's one end is here and another end is the hard palate. Hayton Williams probes and the arch wiring. This is the arch wiring in the closed mouth. Now the procedure for the internal skeletal wire suspension is done through a minor surgery, either with the application of the arch bar, reduction of the fracture by the closed method, or the occlusion is checked, the fixation of the midface to the base skull by means of suspension wires. So fixation of the midface by tightening the suspensory wires and the intermaxillary fixation. And for the edentulous patient, available prostheses are the gunning splint. We have already discussed it. The mandibular fracture, the gunning splint, these are used for the edentulous patient. So treatment of the Leafoot 1 fracture. So in this, the intermaxillary fixation, the IMF fixation by the zygomatic arch suspension, if necessary additional suspension at the piriform aperture. So this is the intermaxillary fixation. Treatment of the Leafoot 2 fracture. In this, the zygomatic arch suspension or the frontal bone suspension, the intraosseous wiring may be done at the infraorbital margins. While in Leafoot 3 fractures, the intraosseous wiring at the zygomatico-frontal sutures suspension, it is used after the application of the arch bar. The intraosseous wiring may be done at the infraorbital margin if the step deformity exists. See, in this you can get a step deformity. If there is a step deformity, then only you can do the intraosseous wiring at the infraorbital margin. So these are the suspension wiring technique. See, we have to do the IMF and we have to use the arch wires, but apart from that, we are also using the maxillary suspension. So what is maxillary suspension? These are the wires which we are using additional with the intermaxillary fixation and with the arch bars. So the suspension wiring technique, first is the frontal bone suspension. So this is the frontal bone suspension. Second is the piriform ring. This is the piriform ring. Third is the circumzygomatic suspension. This is the circumzygomatic suspension. See, there is the presence of either of the arch bar and the IMF. Along with this, we have to give these suspension wire according to the fracture. So like in Leafoot 3 fracture, we have to give the circumzygomatic suspension, and fourth one is the circumzygomatic suspension. Right? So these are the suspension wiring technique which we are using along with this Leafoot 1, 2 and 3 fractures. Now coming on to the open reduction. So open reduction, it is carried out under the endotracheal anesthesia with the nasal intubation, intraoral vestibular incision. See, in this procedure, the open reduction, it is carried out under the endotracheal anesthesia with the nasal intubation. In this, there is an intraoral vestibular incision is made. Fine, and it is made from first molar to first molar. Then after this, you have to raise the mucoperiosteal flap. Why? To expose the fracture line. Fine. After that, after exposing the fracture line, you need to insert the osteotome. Why? To mobilize the fragment. Mobilize the fragments. Fine. After this, then after mobilizing the fragment, you will use the disimpaction forceps. So the disimpaction forceps, they can be used to brought the two fragments in occlusion. Fine. And after this, you need to do the temporary intermaxillary fixation, and in this, the fracture segment, these are fixed with the mini bone plates and the screws. So this complete technique is called as the open reduction. I repeat, see, the open reduction, it is carried out under the endotracheal anesthesia with the nasal intubation. Very important point. And after this, the intraoral vestibular incision, it is made from first molar to first molar, and after making the incision, you have to raise the mucoperiosteal flap to expose the fracture line. And after this, the fracture line, it is made. So this is the open reduction. Fine. Now coming on to the open reduction. So open reduction, it is carried out under the endotracheal anesthesia with the nasal intubation. Very important point. And after this, the intraoral vestibular incision, it is made from first molar to first molar, and after making the incision, you have to raise the mucoperiosteal flap to expose the fracture line. After exposing the fracture line, you need to insert the osteotome while to mobilize the fragments. So after mobilizing the fragment, then you use the expansion forceps to brought the two segment into the occlusion. Then after this, at the last, you need to do the temporary intermaxillary fixation and the fracture segment. These are fixed with the help of the mini bone plates or the screws. So this complete is the open reduction technique. So after the Lee-Ford fracture, next fractures that we are going to discuss are the zygomatic fracture. So the zygomatic fracture, it is unusual for the zygomatic bone itself to be fractured, but in extreme violence the bone may be comminuted or split across. So the isolated zygomatic fractures, these may occur without displacement of the zygomatic bone. Important point, please don't get confused. So coming on to the zygomatic fractures, so there are two types of fracture, the zygomatic complex fracture and zygomatic arch fracture. So the zygomatic complex fracture, it is the separation of the zygoma from its four articulation. The zygomatic arch fracture is the fracture of the zygomatic arch in isolation. Right? So according to Rose and the Kiley's classification, which was given in 1968, in this we have 8 types of fractures, in which type 1, in which there is no significant displacement, type 2 there is fracture of the zygomatic arch, type 3 there is rotation, we have already discussed this, type 3 is the rotation around the horizontal axis, type 4 around the longitudinal axis, type 5 is the displacement of the complex end block, type 6 is the displacement of the orbito-enteral partition, type 7 is the displacement of the orbital segment, or type 8 is the complex comminuted fractures. So what are the clinical features? So the early clinical features are that there will be a swelling and the bruising over the cheek, there is a depressed cheek prominence, the trismus and the restricted lateral mandibular movement. You can very well appreciate the ecchymosis at the maxillary buttress region, the step deformity along the infraorbital margins and possibly along the lateral and the orbital margin and the zygomatic buttress. In this you can see there is a double vision, that is diplopia, that there is an anophthalmos and the bleeding from the nose on the side of the fracture, that is the epistaxis on the fracture site. So these were the early clinical features of the zygomatic fracture. Now coming on to the late clinical features, in this you can see that there is a flattening of the cheek or the flat cheek, the anophthalmos, altered pupillary level, infraorbital paresthesia and double vision, which is the diplopia. So treatment is, in this the stable fractures, these are the simple elevation will be sufficient. Why the simple elevation will be sufficient? Because of the high degree of the stability due to the integrity of the temporal fascia and the interdigitation of the fracture line. So in this no additional fixation is required after the reduction. Fine. So in this we have type 1 in which there is no treatment, type 2 unless vertically displaced, type 3 and type 4 in which open reduction may be required and transosseous wiring is advisable. While in unstable fractures which require the open reduction and the transosseous wiring or the bone plating, in which type 4B, type 5, type 6, 7 and 8, these require the transosseous wiring or the bone plating along with the open reduction. Next is the operative technique, very important. So the approach of the Gillies or the Kilner and the Stone in 1927, they popularized the reduction of the fracture of the zygoma. So this technique is known as the Gills technique or the Gillies temporal approach. Now after this, let's discuss the steps of the treatment or the steps of the temporal approach for the reduction of the zygomatic arch. But before discussing into detail, let me tell you some brief about this complete procedure. See, this is the Bristow's elevator which we are going to use in the Gillies temporal approach. Fine. So this is the temporalis muscle and this is the temporalis fascia. Fine. So this is the temporalis fascia. It is attached to the zygomatic arch, while the temporalis muscle, it is passed downward medially to the fascia to attach to the coronoid process. Fine. So the Bristow's elevator, we insert this into this complete temporal region. So starting with this, so in this, first the hair is shaved from the temporal region. Number one, the hair is shaved from the temporal region of the scalp. In this, the external auditory meatus, it is plugged. The external auditory meatus, it is plugged with the cotton. Why? To prevent any fluid or blood getting inside the external auditory meatus. So after this, an incision is made. Fine. So incision is about, please note it down, incision is about 2 to 2.5 centimeter in length, which is made, and it is inclined forward at the angle of 45 degree to the zygomatic arch. Guys, very important, commonly asked MCQ, that the an incision is made about 2 to 2.5 centimeter in length, and it is made forward at the angle of 45 degree to the zygomatic arch. Fine. So in this, after making the incision, you have to take care to avoid any kind of injury to the superficial temporal vessels. Fine. So in this, the temporal fascia, this is the temporal fascia. The temporal fascia is exposed, which is identified as, this is the white glistening structure. This is the white glistening structure. Fine. So in this, the incision is taken into the fascia, and the fibers of the temporalis muscle will be seen. These are the fibers of the temporalis muscles will be seen. So in this, this is the long Bristow's elevator, periosteal elevator. It is passed below the fascia. This is the fascia. It is passed below the fascia, see, and above the muscle. So Bristow's elevator, it passes below the fascia and above the muscle. Fine. So once the Bristow's elevator, it is in the corrected or in the correct plane, it identifies the instrument, it is inserted. How the instrument is inserted? It is inserted in the downward and in the forward, D and F, in the downward and in the forward position, and the tip, and somewhere around here, the tip of the instrument, it is adjusted medially to displace the fragment. Fine. And after this, a thick gauze pad or the thick gauze piece is kept on the lateral aspect. A thick gauze piece, it placed on the lateral aspect of the skull. Why you need to put a gauze pad on the lateral aspect of the skull? Why? To protect it from the pressure of the elevator while reduction is going on. Right? So the tip of the elevator, this is the tip of the elevator, it is manipulated in which direction? In U, F, O. It means in upward direction, in forward and in outward direction. When you are manipulated, when the tip of the elevator, it is manipulated in these three directions, you will hear a snap sound. Snap. You will hear a snap sound. Fine. As soon as the reduction procedure is completed. So after this, the wound is closed in the layer. And you withdraw the elevator, and care is taken that 5 to 7 days there will be no pressure exerted on this particular area. You need to instruct the patient that not to sleep in the operated site. Fine. So this is all about the Gillies temporal approach. So this is the extraoral approach. Mind it. Coming on to the intraoral method. So the intraoral method, this is called as the intraoral or the Keene approach for the reduction of the zygomatic fracture. See, in this, the Keene's approach, it is given 1909. So in this, the IBV, the intraoral buccal vestibule incision is given or is taken in first or the second molar region. In the first or the second molar region, you can give the intraoral buccal vestibule incision. So a pointed curved elevator, this is the pointed curved elevator or the Monk's Patron elevator, MONKS, Monk's Patron elevator. It is passed supraperiosteally up beneath the zygomatic bone. So the depressed bone is then elevated with UFO in the upward, forward and outward movement. So this is the intraoral method for the reduction of the zygomatic bone or the arch fracture. Fine. So after this, next are the fractures of the floor of the orbit, which is called as blowout fractures, important for your competitive exam. So the blowout fracture, these occur as a result of a direct trauma to the orbit with an object larger than the globe size, like a Costco or a cricket ball injury. Here primarily there is an increase in the hydraulic HP, hydraulic pressure within the orbit, which results from the compression of the orbital content. So there is a direct hit from a globe like thing, like a Costco ball or like a cricket ball. So what all are the clinical symptoms? This you can see that there is a circumorbital edema, circumorbital ecchymosis and ophthalmoplegia, diplopia of upper and the lateral gaze. Very important feature of the blowout fractures are, you can see an ophthalmos. So the diagnosis, it can be confirmed by the force duction test and hanging drop appearance in the PA view. Very important MCQ. Waters position radiograph or by CT scan, but first preference is the PA view or the Waters view. Coming on to treatment, so in this, the surgical exploration of the orbital floor and the reconstruction of the orbital floor by the celastic sheet or the bone graft whenever necessary. Otherwise, balloon support or the ribbon gauze packing, it can be used in the maxillary sinus. And what all are the grafts? See, the orbital floor reconstruction, this we need various grafts. We need autograft, allograft or alloplast. So the autograft are the rib, you can take it from the rib, iliac crest, calvaria, as well as from the ear, as well as from the nose cartilage. And allograft, you can take it from the lyophilized dura from the rib, iliac crest and the cartilage. And the alloplast, you can give like a Teflon, Celastic, TI mesh and the gel film, which are described for the orbital floor reconstruction. Coming on to the last fracture, which are the fracture of the nasal bone. These are the high incidence because of the prominence of the nose, usually due to the direct injury, and can occur as an isolated fracture and may be combined with the other facial fractures. So the nasal fractures in the children should be generally treated conservatively and with the closed reduction because of the growth potential. Important. Anterior injuries, the direct, violent. There are two types of injury, the anterior injuries and the lateral injuries. Coming on to the anterior injuries, these are direct, violent, important. Or anterior force may be result in the smash fractures of the nasal bones, the frontal process of the maxilla and the lacrimal bone and the septum. So in this, the comminuted fragments, these may be driven laterally into the orbit or the upward into the ethmoid region. So the splayed nasal fractures may be associated with the damage to the nasolacrimal ducts, the perpendicular plate of the ethmoid sinuses, the cribriform plate, and the orbital parts of the frontal bone. There is a widening of the intercanthal distance, which is called as traumatic telecanthus. Important feature for your MCQ. There is a buckling of a nasal septum may be seen in this anterior injuries. Now coming on to the second injuries, which are the lateral injuries. When the force applied from the side of the nose, it may involve the nasal bone or the medial displacement, but commonly involved in the adult as a violent blow from the side, which results in the fracture of both the nasal bone and the fracture of the nasal septum with the lateral shifting, important, of the entire bony framework. So when you get a hit in front, this is the anterior injury. When you get a force from the side of the nose, this is a lateral injury. So this is also known as open book fracture, guys. Very important, commonly asked MCQ. The open book fracture, it is only seen in the lateral injuries. The nasal septum is collapsed and the nasal bone is splayed out. In most severe injuries, the septum may be fractured or it may be displaced from the maxillary crest, from the vomerine or the vomerine groove, or from its attachment at the anterior nasal spine of the maxilla with displacement into the adjacent airway. So the fracture of the septum occur in the vertical plane, and there may be telescoping or overlapping is seen. Important. So what all are the clinical features? In this you can see that there is a depressed or the flattened nose, the flattening or the deviation of the nasal bone. You can see hematoma, subconjunctival hemorrhage. Nasal obstruction may be caused by the edema, blood clots, swelling of the nasal mucosa, dislocated bone and the cartilage. There may be subcutaneous emphysema, which may be present because of the patient repeated attempt to the blow nose, circumorbital ecchymosis, cerebrospinal or the CSF rhinorrhea, crepitation and the tenderness, active bleeding or the bleeding from the nose should be taken care immediately. Coming on to the last part, that is the management. So in this you can do the close reduction is the treatment of the choice for most of the nasal bone or the septal fractures. These fractures should be repaired within 7 to 10 days. The close reduction can be done under LA with or without the sedation of the general anesthesia. Very important point is it should never be conducted under intravenous sedation. Please note it down. So the two specially designed instruments which are used in the management of these fractures are the Ash and the Walsham's forceps. Important. So guys, this is all about the middle third fractures. Please go through it once and try to make the notes. Thank you.